Good evening. My name is Jen Handy, and I am the SHEP's Director of Grants and Engagement. Thank you for joining us tonight for our first Practitioner Insights events for this summer. These events are designed for the SHEP community, specifically you, our interns, to have a chance to hear from innovative and dynamic leaders doing anti-poverty work. We have asked our guests to come on and talk shop about their job, about the trends they're seeing in their fields, but they also are going to talk a little bit about their career path so that you can kind of see how they took their undergraduate work and other things and kind of got where they are today, because we're all still trying to figure out where we're going. Two of our guests this summer, including tonight, are SHEP alumni, and we get to hear specifically about how their undergraduate experience impacted their postgraduate life. These events, as evidenced by some of the, more relaxed setting and bad jokes being told before we started, is designed to be a little bit more informal than our academy speakers or the upcoming conference. So we're going to start out by hearing from our guests, and then we'll have a chance for questions. So you probably, if you want to keep your screens on so we can see smiling faces and she doesn't have to kind of talk to a blank slate, but maybe keep your microphones off for now. One more thing to know before we start: some of our interns are working evening shifts with their community partners. A few are attending community meetings, so we are recording the event, and I am going to try as hard as possible to have it up as soon as possible. So tonight we have Dr. Kyle Meehan joining us from Arizona, and if you go online, you will see a very long, beautiful resume, and I think it would have taken the 45 minutes for me to kind of parse out all the different steps. But thankfully, she's going to kick us off by telling us a little bit about her journey and the work she is doing now, and then we're going to have a little bit more of a conversation. So take it away.
Thank you. I'm really excited to be here, and I'm really excited to have Dr. Beckley joining as well. He is incredibly important to me, as his entire family is incredibly important to me. So seeing Debbie, his incredible wife, on screen as well is really lovely. So I'm just going to tell you a little bit about myself and my journey and how the Shepherd Poverty Program was part of that for me, and then open it up to questions. I'm going to touch on some of the kind of key aspects of the work that I'm doing now that I feel really touches on the anti-poverty work. So my first name is Elizabeth. I go by Kyle since I was born, and I am currently at the University of Arizona within the family medicine department here. So I will talk a little bit more about that. Let's see. So how I came to being a family medicine doctor, I tried to put kind of the highlights of my journey. I'm originally from Connecticut, grew up half of my life in the capital of Connecticut, which is Hartford, and then moved out to more of like a rural town or suburb of Hartford, and that's where I graduated from high school. Then I went to Washington and Lee. I graduated high school in 2001. So I was at Washington and Lee from 2001 to 2005. And at that time, took Poverty 101 from Dr. Beckley. And really it set me on a course. I always knew that I wanted to be involved in social justice work. And at that time, going into college, I didn't know I wanted to be a doctor, but it really set me on my course. And I want to say more than anything kept me on my course. So I was an English major and did the pre-med courses, which is like a bunch of science classes that you have to take, as many of you on this call are taking and know of, and then did the poverty studies. At the time, it was considered a concentration, but now it's a minor, is my understanding. But in 2003, I was a Shepherd Poverty intern and got paired with an incredible person who is no longer alive. His name was Dr. Robert Maslansky, and he had graduated from Washington and Lee in the late 50s. And at the time that I worked with him, he was in his early 80s or late 70s at least. And he was one of the first prescribers of methadone in the entire United States. And he was in New York City at Bellevue Hospital, and he worked with a researcher who was very famous, who was one of the first researchers on methadone and the administration of methadone in the United States. And her name was Jean Marie Creek, and she was out of Stony Brook Hospital, which is on Long Island. And I went and was got to be in New York City for the summer, got to work with him. And that summer it was, I was trying to remember, I think it was between sophomore and junior year. So I was kind of knee deep in the sciences, and definitely the English stuff came more naturally to me. The writing came more naturally for me. And I was starting to think and doubt myself, like whether or not medicine was right for me, and, you know, being in physics and all of those other courses that were quite challenging. And when I got to New York City that summer, I was able to see an interdisciplinary team that was caring for people with substance use disorder, specifically opioid use disorder. And at the time, more heroin than anything. Nowadays, we're seeing, and I take care of a lot of people with opiate use disorder, but seeing more fentanyl and more prescription pill misuse. And however, at the time, it was a lot of people using heroin and mostly using it IV. And so at that summer, I got to participate in a lot of different things, but I think the most meaningful part of it for me was getting to see the team of people that were caring for these clients and patients that were coming through the door. There were, you know, the doctor, there were nurses, there were drug and alcohol counselors, many of whom had struggled with their own substance use disorder, that were part of these patients' teams. There was a dance therapist, there was a psychologist, so lots and lots of different people, social workers, housing specialists that were working to address these patients' needs. And I did find all of those jobs to be quite rewarding, but found the job I was still most attracted to was medicine. And so coming back from that summer in New York, it really helped me realize that, like, I got to buckle down. This is what I want to do. And there's not an obstacle that's too great to get past. So let's keep working at it. When I was at Washington and Lee, I also did a longitudinal volunteer work through the Rockbridge Area Free Clinic. And that was really eye-opening as well. So I had gotten the experience of working with patients from New York City, very urban, obviously, and then more of the rural clientele that had different barriers to care and barriers to their healthcare. Often it was the long distances that needed to be traveled, the accessibility for certain treatments that made it challenging for people to get care, specialty care, or advanced care easily. And so I graduated from Washington and Lee in 2005. I did a capstone project that combined my English major and poverty studies, and ended up writing about how poverty was represented in different literature, in literature that I was reading. And then also wrote about how I believe healthcare should be is a human right and should be accessible to all, and the benefits, the downstream benefits of free healthcare for everyone, universal healthcare. So I graduated from college knowing I did want to go to medical school, but not quite ready to do that, and ended up moving back home to Connecticut and worked in Hartford for an organization called Partnership for Strong Communities. And this organization is a research institute, public policy network, and lobbying for, like, work hand in hand with a lobbying firm, essentially as to advocate for supportive housing as a long-term solution to homelessness in the state of Connecticut specifically. But Connecticut and New York back in 2006, 2005, early 2000s was really advanced in understanding the idea of harm reduction. I'm not sure if that's a concept that you all have talked about. You can talk about harm reduction in a lot of different ways, specifically also with substance use disorder. Needle exchanges are one example of a harm reduction program, where if people are going to be experiencing certain risks in their lives, how can we make their risk less? So yes, they may continue to use drugs, but can we make it so that they're not contracting infectious diseases that they cannot cure, that will complicate their lives while doing it? And there are even more progressive ideas around that, with like safe use housing, safe use havens, where people can go and use substances while being monitored by a medical team. And Philadelphia is experimenting with that right now. It's the first in the United States. There's, it's really well known in Vancouver, Canada. But from a housing perspective, there's a lot of reasons that people are unhoused. And if we expect people to get housing and then fix the reasons that they're unhoused, that's not really likely to happen, because the instability of not being housed is often the problem, which makes it so that getting clean or getting out of a domestic violence situation or intimate partner violence situation, or mental health that's unstable, if they had stable housing, they may be better able to address those needs. And so the Partnership for Strong Communities does a lot of work around that. And my job was really awesome. I got to travel around the state of Connecticut and interview people that were beneficiaries of supportive housing and kind of hear their life story and then how supportive housing impacted their life. And then I took those interviews and actually made them into like one-page op-ed articles in the newspapers, or used it as lobbying paperwork at the state capitol. And it really took my love of stories and storytelling and the power of stories to advocate change. And I was able to do that. So after that year, I ended up deciding to go to medical school, and I chose to go to Jefferson Medical College, which is now called Sidney Kimmel Medical College or Medical University, and that is in Philadelphia. And while I was there, I participated in a number of different programs that were specific to the work that I wanted to do around anti-poverty work. But one of them was I was in an urban underserved program, and it was a track where my clinical work was preferentially placed in urban underserved settings where the patient population was a more marginalized or vulnerable population. And so when I did surgery, I did it in North Philly. When I did all my outpatient family medicine rotation was with patients who are uninsured. And so I got to get more experience with that. A great story that Dr. Beckley probably doesn't remember, but knew of at one point, was that summer I was working as a part of that longitudinal program is I did a summer internship where I was working at a domestic, a shelter for women that were experiencing intimate partner violence. Some of them had dual diagnoses with substance use disorder and mental health diagnoses. And I was serving lunch, like hairnet, everything, with serving lunch to my clients. And the shelter actually opened up to free meals for any women in the community that needed meals. You didn't necessarily have to be housed at that shelter. And I was serving food, and this woman comes through the line with this like pristine power suit is the best way to describe it. And I look up, I'm wearing my hairnet, I'm serving like lasagna, and it is one of my friends' acquaintances from Washington and Lee, who was also a Shepherd Poverty intern in law and now was doing law. And she was representing a client who for a pro bono case, and her client had food insecurity. And so this was on the list of places they could go. And she was essentially having a lunch meeting with her client over the free meal that I was serving. And so it was like the perfect marrying of bringing Shepherd Poverty interns together from all different aspects of their impacts throughout different careers. So pretty exciting. That was Leah Greenberg, now Katz, Dr. Beckley. So after graduating from medical school, I decided to go to San Francisco General Hospital, which is UCSF, for residency. And I specifically chose to go there again because they kind of focus on urban underserved care. And everyone that gets taken care of at the General Hospital is either uninsured or underinsured with Medicaid. And they do not take private insurance at the General Hospital unless you're a trauma patient in the city, because it's the level 1 trauma center for the city. And when I was there, San Francisco actually essentially had a universal health insurance plan. It was not portable. So if you went over to Oakland and you had something happen to you in Oakland, your insurance plan, it was a health access program. It wasn't necessarily insurance, but within the confines of the city of San Francisco, any healthcare needs you had, including Uber specialists, if you needed to see a neurosurgeon for spinal cord injury, you could see a neurosurgeon with the Healthy San Francisco program. And that was really eye-opening. I feel like I learned so much in residency. And then when I was no longer in San Francisco, all of a sudden it was this rude wake-up call of like, oh, there's people that just cannot get care because they do not have health insurance and there's no health access program. And so when you go to San Francisco, your food bill is a lot more than you would expect often because there's a Healthy San Francisco tax that you pay on your your meal, which that then goes to pay for people who don't have access to healthcare for their insurance. So after graduating from San Francisco, I decided I really wanted to stay involved in academic medicine, which I can talk with you all about more, and have essentially been residency faculty here at the University of Arizona since. I graduated from a chief residency year. That was a faculty development year in San Francisco. While I started my faculty position here, I did do an integrative medicine fellowship. So I'm trained in alternative and complementary medicine, which for me is an interesting place to be because it's often associated with services that are not covered by insurance or easily accessible to people because of the way our healthcare system values alternative and complementary medicine. And so the practitioners are often a little bit more inaccessible to people, but there are different organizations that I belong to. One of them is called Integrative Medicine for the Underserved, that kind of talks about how we bring complementary and alternative medicine to people that are unable to pay out-of-pocket fees. So residency education in combination with serving the population of patients that I'm most passionate about is where kind of my expertise, I think, in medicine lies. I chose family medicine because I wanted to take care of everyone. Jen and I were talking a little bit earlier about I have a very curious mind. I'm always wanting to add a lot of different things. I like the diversity. I like not knowing really what's going to walk in next. The chaos does not stress me out. It actually excites me. And so I can have 15 patients, that I see, or 10 patients in a half day. And one patient is a pregnant woman that I'm doing her prenatal care. The next patient is a 95-year-old person that I'm having an end of life care discussion with. And then everywhere in between, someone there for an acute visit for concern for UTI or an STD. And then somebody who is there with their multi-generational family. And I'm the doctor for all of them. It's really, really rewarding work for me. And it's really exciting. I think family medicine is really undervalued in our country. Primary care is really undervalued. And honestly, I think a lot of our problems with our healthcare system are because of that. But I have a narrow slice in that ability to make change. And I've really chosen to do it through educating residents and medical students to go on to impact communities that once they graduate and decide what they want to do. So our family medicine program here at the University of Arizona, you can read our mission statement. I won't read it to you, but it really is focused on attracting residents that want to care for vulnerable populations. We had two residency programs that merged together, and I used to be the program director of one of the programs down at South Campus, which specializes in rural practice, which was very new for me. I said I had in Connecticut, there's really nowhere that's so rural compared to Arizona. Arizona by landmass is just massive. I feel like I could go from Connecticut, where I grew up, all the way to Virginia, and I'm like still in Arizona, more or less, just landmass here. And so rural America is something very new for me. Some of you may be from rural America and understand that way more intimately than I ever will, because I still live in an urban setting. But Arizona ranks like varying years, like between 46 and 49 on like worst healthcare for the population. And one of the major reasons is the complications, I guess, of our state are our border proximity with Mexico, and the migration that happens with people and what they're able to access because of documentation status in the United States. Number two is Arizona has the largest land mass of native land in all of America. And as you know, native people have been completely mistreated historically in our communities and are very underserved and are not fairly compensated for the land that we took from them. And then the third piece is that we have a lot of rural areas. So the closest doctor, closest specialist for certain patient populations is quite far. So I'm going to touch upon all of those. So this is Arizona. I don't know how many of you are, maybe some of you on this call are from Arizona, but the Southwest was a new place for me. I'd done kind of bi-coastal living, but hadn't spent a lot of time here. And I put this map up because it shows actually our rotations where our residents go. So we are located in that area that's circled, that's Tucson. As you can see, Tucson is pretty close to Mexico. We're about 60 miles from Mexico, or a little bit over an hour drive. The closest border town is called Nogales, and there's a Nogales, Arizona, and a Nogales, Mexico. And then there's another border town that's really well known and often in the news, which is Douglas, Arizona, and Agua Prieta is the Mexican side of the border. And then there's other ones across the border, Sonoita and Puerto Penasco and some other places. But you can see where Tucson is compared to Nogales. Nogales is the black dot down, or black star. And then everywhere that there's a star is where our residents go for rotations. So even though we are based out of Tucson, our residents work on Navajo Nation. They work with Hopi in Palaca, Arizona, which is up near the Four Corners, which is New Mexico, Colorado, Arizona. And we also go to some other more like mining towns and some other areas. All of that like Manila cream color is actually native land. So you can see by land mass, it's quite large. The Navajo Nation, which again is Four Corners, that is the size of West Virginia. So it's a huge area of our country. So we a couple of things that I just wanted, parts of my job that I wanted to talk about. We run a mobile health clinic that was started in 1976 by a visionary similar to Tom Shepard, who started the Shepherd Poverty Program. Dr. Ortiz and his wife, Martha, were interested in figuring out how they could serve the diverse community of Southern Arizona, specifically people that were uninsured or medically underserved. Our university, our department now runs two units. There's like a mod that gets pulled on a tractor and an actual van from the March of Dimes. And they go all over Tucson. We take care of primary care patients, as well as my role with this program is for prenatal patients. So I was there this morning. I saw 10 patients, 5 new patients. You can see our statistics from 2021. 100% of our patients lack insurance for prenatal care. 92% fall below the federal poverty line, and 83% were an ethnic minority. Many of our patients are monolingual Spanish speakers. Many of them have mixed documentation homes. So they don't have documentation, but maybe their partner does, or a child does, or one child does and one child doesn't, which creates a lot of complexity. And our program does the entire prenatal care for free, as well as the delivery is then on a very reduced scale, fee for service, sliding scale. So just wanted to highlight that. I also wanted to show this slide and the next slide that kind of talks about our border. This slide has a lot of words on it, but the main point is I just wanted to highlight one of the main things that I'm doing is a lot of border health. So I'm taking care of a lot of patients who are migrating back and forth. I think sometimes there's this misperception that people are coming to America and are not leaving America, but actually there's a huge migratory flow back and forth, and essentially people going from Mexico to the US and US to Mexico is about the same, to be honest. And we are seeing a lot of people from all different areas of the world coming through Mexico. So Mexico has the Mexican border with the US is the largest migratory flow between any two nations in the world. But the idea that the misperception again is that there are people coming from Mexico. And we are seeing most people now coming from Central America and actually African countries. Mauritania is another country that we're seeing a lot of patients from as of late. And so it's always very interesting to me. I'll hear of a country that I don't know where it is because I'm not great with geography. And I'm like, wow, that's weird. I've taken care of 4 people from Mauritania in the last 2 weeks. Where is that? And what the heck is happening in that country that people are fleeing persecution and situations that are not okay? And so then I learn about the world and what's maybe happening in other places. Interestingly, from a doctor's perspective, the things I get to see, I had a case of malaria the other day. A patient came in and was admitted with malaria because they were from a country in Africa that malaria is more common. So, things that as you guys get closer into your medical fields, if that's what you decide to do, we call it a differential diagnosis. So the things that should be on your differential of what might be going on with this person is just blown huge. It's global, right? What we could potentially be seeing. it's pretty interesting and exciting. We had a case of disseminated tuberculosis throughout the whole body, things that in the United States, you don't typically see some of these things. And then the things that we see because of border crossing is also really interesting. There are some cases that I just had never seen in other countries. I see more syphilis here than I've seen anywhere else. I've seen neurosyphilis. So like the medieval times person that's like can't walk because their balance is all off and they're doing wonky things and hallucinating. I see that on a pretty regular basis. We get spinal taps of patients that have syphilis inside their spinal fluid, which is a pretty rare late finding. And a lot of times people present to care very late because they have no other options. They are afraid for various reasons to go seek a medical care. And they also don't have the money or the insurance status to do that. So we see some really interesting things. I'm an asylum seeker, forensics. I do forensic medicine through asylum medicine, which means that I'm on a short list here in Arizona where when a patient is seeking asylum, they can essentially apply for special documentation to have an exam done by a physician. It's either a medical physician, well, psychiatrists are medical physicians, but it's a mental health evaluation through psychiatry or a physical evaluation through medicine. And I am able to go and take part of that. And I'm going to pull this up because I was looking it up last night. I always say this and I was like, I don't know if this is true or so I have proven or documented that it is. There was a study that basically showed if a medical doctor provides appropriate documentation with clinical evidence about why somebody's seeking asylum status, so that they were a victim of torture or violent persecution, psychological impacts or physical, their chances of successfully getting asylum status goes from 37.5%, that's without the medical documentation, to 89% with a medical document. So the likelihood of getting asylum status is much, much higher. We do not have enough people that are trained to do these exams. I did my training when I was a resident in San Francisco, and I got picked up to go to a party by an Uber driver later that night. And he was like, "How was your day? What did you do?" I was like, "Well, do you really want to know what I did?" So I ended up telling him that I had learned like how torture happens and what it would look like on the body if people experience certain type of torture. I was like, "Oh, I guess I'm going there." And he goes, "This is great. I'm a stand-up comic in my free time, and this is going to be a great story someday." I'm like, "Oh my gosh." But the job of a doctor is never boring, as the job of an Uber driver is probably never boring either. So that's what we do. The definition of being an asylum seeker is that you have to essentially have persecution because of something that you cannot change about yourself. So that could be your religion, your sexual orientation, the fact that you're a woman, different ethnic groups that you may participate in or identify as. So things that are not modifiable that you are then being discriminated against for. I think this quote is true. Interesting fact, there's the International Rescue Council, which is essentially asylum seeking refugee work that's happening all over the country. It was started by Albert Einstein. So again, like your path doesn't always have to be one thing. Nobody knows that about Albert Einstein, or I didn't at least know that about him. So he was not just a mathematician, he was also a human rights advocate. So it doesn't matter what you decide to do with your life, you can still be a human rights advocate in any avenue of it. I just have 2 more slides. I'm proud of the work we do. Again, I'm not going to read this to you, but you can kind of see the benefits of having a program that is very mission driven. We end up training residents that go on to do the work in healthcare professional shortage areas in rural America. They do multi-spectrum family medicine, meaning that they're not just practicing outpatient primary care, they're also doing inpatient OB, other things like that. And we have a global health track, and a lot of our graduates go on to continue to serve globally. And then this is just a picture of some of our alumni and what they're doing. We have a large group of our residents that go on to work on with the Indian Health Service. The woman in the middle, she's actually Dene or Navajo herself, and she's now the chief medical officer of her entire hospital. We have people out in rural Arizona and people that have gone on to do academic medicine elsewhere to hopefully continue to train residents to do so. But our residents are really amazing, and I'm proud to work with them. So that's a little bit about me and the work that I do. And I'm happy to answer any questions. And I'm going to stop sharing so I can see more of your faces at once. But yeah, the poverty program was hugely impactful for me. And the opportunity to get to talk with all of you was really exciting for me because of that. So thank you for being here.
So I'm going to start with a couple of questions, and then to give everybody else a chance to think. In a minute, you can unmute and you can ask about her journey or her work, very specific questions about things. You get to go anywhere with this. I have just a couple. How you talked a little bit about how your undergraduate kind of experience in your poverty studies minor, what was the concentration then, kind of impacted that journey. Can you talk any more about that?
Yeah. I grew up in a household where my parents were very social justice focused. My dad, I think it's like many generations, and I feel very lucky for that. My grandma like dragged my dad to go see Martin Luther King Jr. speak. And like, there's a picture that often gets posted around that, the day, his birthday, that my dad's in the picture from when he was like in 6th or 7th grade. So growing up, my parents were really, it was a big deal for us to recognize our privilege and to recognize the way that we could serve and how we could be a part of it. But I think I always knew about kind of doing the work or understanding that I had a lot more privilege than the average person, and therefore how did I want to impact the world? But I didn't have the intellectual understanding of like, I didn't know what the federal poverty line was. Like, I didn't understand simple definitions. And I remember, I don't know if it's still this way, but Poverty 101, the final paper was, what is poverty? Period. And then you just write. And I don't even know what I wrote. Dr. Beckley probably doesn't remember either, because he probably read so many of our papers of that. But just that intellectual conversation and dialogue and understanding that it's far more complex than financial, that voicelessness, powerlessness, being marginalized, and equity versus equality being very different. There's a great picture that I will try to find of like people with fences. Have you all ever seen that picture of the difference between equity and equality? And I think we sometimes get it wrong, and often too, we think we know what maybe other people need or communities need instead of asking questions. I think the concentration helped me to learn and ask more questions rather than, I didn't have answers, and I don't know if there are answers, but rather than doing a needs assessment of a community, go in and do a strengths assessment. What is the community doing well? What do they want? How do you empower the people that are in the community to do the work they're doing, rather than saying like, oh, I have a solution from somewhere that I actually know nothing about, right? Like, I am not Native. I don't know much about being Native and growing up Native. And so when my patients come in, there's things that I need to be curious about, and I need to hear what they need and how I fit into that as just simply an empowerer. Like, I don't have the answers. They have the answers for their communities. And so I think reading different things, that kind of different texts or different theorists, different public policy experts, and hearing like, what is poverty and how are all the ways that we can impact it. But also, I loved that it was interdisciplinary. So I come from it now, and at the time thought that I wanted to do work in medicine, and that turned out to be the case. But there's so many people that were in my cohort. Like, for example, my roommate, when I was living in New York City, she was working with at-risk youth they were taking they were essentially making boats. It was called Rock the Boat, and it was up in Harlem, and they would build boats, and then they would sail the boats around Manhattan and do scientific, work and like pollution activism. And that was a totally different thing. It was like getting children engaged and teenagers engaged in projects that would better their community. And it was so different than what I was doing, but it was equally addressing a need within a community. And so we went to Berea College for our like kickoff, and that was amazing to learn about that college, and to, some of you may be from there or go there now, and to learn about how that community worked, and was so different than Washington and Lee, which was just one perspective for me. And I loved it. I loved getting to work with people from all different colleges. I think the consortium continuing to build, I think it's bigger now than it ever was when I was part of it. But I think that's one of the greatest strengths of it. Learning from different perspectives, even from the other interns, was really powerful.
Great. Anybody? I have more questions because I am a deeply curious person. But wait, Alan, you can like unmute and just like go for it.
Hey, Dr. Meehan, you mentioned differential diagnosis. Would you be able to tell us more about that and like what that entails, particularly in a clinical setting?
Yeah, perfect. So when somebody, I think everyone's like, you were an English major in pre-med, that's so weird. And on one hand, it kind of seems weird, but it's actually not, in that every person that comes to you is telling you a story. And doctors are infamous, not famous, infamous for interrupting people and cutting them off when they're telling their story. It's something like within 30 seconds, you will be interrupted by the doctor. They won't let you just tell your story. And actually, if you just listen to what people are telling you, you can often come to a more accurate conclusion and help them more if you just let them tell your story. So coming up with a differential is essentially that. So somebody comes in and they tell you their story of what's bothering them, and based on likelihood or probability, because of their age, their sex, their other risk factors in their life, sometimes their race or ethnicity, but not always, or more often not related to that, where they live. Are they living in a shelter? Are they living in a house, their own individual house? Do they have access to clean water? Like all of those things that come into play. The social determinants of health is huge for figuring out what risks people may have of certain illnesses. So for example, the same presentation, you have a 60-year-old person that comes in and they say they've been having fever, nausea, and confusion for the last 3 days, versus a 22-year-old who comes in and has fever, nausea, and confusion for the last 3 days. The differential for the exact same presentation is going to be very different based on the age and maybe the risks that that person engages in at the age of 60 versus 22. And so you may be thinking more like substance use when they're 20, or you may be thinking more of like a urinary tract infection when they're older. But have they recently traveled somewhere where they could have also eaten something that is causing their symptoms? So differential diagnosis is, what is the possible diagnosis that this person has? And the way I was trained in residency was there's always going to be a most likely or a couple most likelies, and then a less likely, and then a must rule out. And that's kind of how I frame things. So the must rule out is, if you missed it, it would be a really big deal. So somebody comes in and they're complaining of chest pain and they're 25, they probably are not having a heart attack, but that's a must rule out, right? Like it's an easy thing to rule out. We can't miss it, because if we miss it, even though they're 25, that would be devastating, right? And so most likely this person has acid reflux, or they're a big weightlifter, so maybe they have a muscle strain. But it could also be less likely. It could be that they have pancreatitis, inflammation of their pancreas, because they're a heavy drinker or something like that. But we must also rule out that they don't have a heart attack that's causing their chest pain. So again, the more interesting your population is, the more interesting your differential diagnosis gets.
And so that's what you were saying, some of the travel really changes it. So where you would rule out is very unlikely it's X, Y, or Z, and a normal kind of, with less travel, with so much influx of from different countries, the prevalence of disease in those countries come into play too, where maybe another doctor in Connecticut would not be looking at likely as malaria, where you would have seen it more often.
Yeah,
So
like I can give you a great example of that actually, without the social determinants of health and poverty play in it. So during COVID, we live where our house is, we have some land, and we had a bunch of people that were decided to give up regular life, and they had like an RV situation where they could work from home. So we, for a while, were like the hot house where people would just park an RV and just hang out with us for a while. And my husband's college roommates, mom and dad, decided that they were going to do this traveling around in the van situation. They came and stayed in Arizona. They were camping, and then they stayed with us for about a week and a half. And then they ended up going back to New Hampshire, which is where they're from. And about a month later, she got really sick, really, really sick. And she was having like pneumonia symptoms essentially, but like fever and body aches, and they couldn't figure out what was going on. And she ended up being like the most interesting case that this Dartmouth hospital had ever seen in recent time, because she had something called valley fever, which is caused by a spore that is in the soil here in Arizona. And so because they had been camping in and around Arizona for a while, she was actually exposed to that, but she didn't think 3 months later to mention, oh, I'd been in Arizona for so long. And so she actually sent me a picture, and she's like, what do you think is going on with me? Like, I'm this and this and this. I'm like, you should have them test you for coccidiomycosis is the fancy word for valley fever. She's like, what? And I was like, it's called valley fever. It's really common here. I have taken care of hundreds and hundreds of people. I had valley fever when I was pregnant with my second child. Super common, but if you're in New Hampshire, it would never, ever, ever be on your differential diagnosis. So the next day she calls me, she's like, the infectious disease doctor thinks you're brilliant. And I was like, I am not brilliant. It's just, we see it all the time. And you were here, and like your symptoms are classic for cocci, right? And so that's an example of like our differential can be narrowed because we don't ask the right questions, or our patients don't offer all the information. And if you have a different perspective of what's common in wherever you are, it's a little bit easier to solve the problem or the puzzle. Does that answer it for you, Alan?
Yes, thank you so much.
Anybody else going to be brave?
I have a question.
Yeah.
I was wondering in trying to preserve this curiosity with the people that you interact with, when the days get long and you're seeing a lot of people and it's getting stressful and it's at the point where you don't really have the time, like how do you kind of protect that part of yourself and that curiosity? Because in a high stress environment, it's really hard to like take someone who's yelling at you, for example, and take that time to be curious and understanding.
Yeah, that's an amazing question. And actually, I just answered it yesterday because we started intern orientation and we had the residents come over to my house, and one of the residents asked that exact question. I really, truly, first of all, if you are interested in making a lot of money, even if you're like the most uber duper specialized doctor, family medicine infamously does not make very much money in the medical field. So you should definitely not go into family medicine, but I would not recommend going into medicine at all if the reason that you're interested in it is family or somebody else thinks you should do it, because it is a really hard job and you can make money a lot more easily with less hours and a lot faster and a lot less heartache if you go into some other career. But if you decide that medicine is the way that you want to serve the world and your gifts are suited there, it is the best. I have hard days for sure, and days that I'm exhausted. I was just telling Jen, Arizona got hit really, really hard, in Tucson in particular, by COVID because of the health inequities that are here. And then we also attract a lot of old people in the winter because of it being a warm spot. And so we went from seeing like an average of 1 death a month on our inpatient adult service to about 15 deaths a week. And it was really, really rough. So there are a lot of hard things, but I do it because my heart wants to do it. I love it. I love attending to people. I love people's stories. And so even on my hardest days, there's always something rewarding that happened. Like, I'm not going to lie, this morning in clinic, we were only supposed to have 2 new patients and 5 ended up showing up, and they came with these like stacks of like records in Spanish and didn't speak English. And one lady was from Sierra Leone. She didn't even have records, and she's like about to deliver her baby and telling me that in the first pregnancy, they had to give her some medicine because she was so swollen and they had to induce her early, and like all these stories. I'm like, what is happening? And it was very stressful because people were backing up and we were late and I was feeling overwhelmed. And then I just had to like go to this place of saying, I have to serve the person in front of me the best I can. And I can apologize and say, I actually don't apologize anymore for being late. I just say, thank you so much for being patient, or you have the patience of a saint. I appreciate you. I don't apologize anymore, because it's not like I'm sitting over there eating bonbons. I'm working my tail off and haven't peed the whole morning either. So, I'm running around like a chicken with my head cut off. So I think if you can really drill down into the meaning of your work, purpose really drives happiness within your fruitfulness in your job, but also prevents against burnout. There's a study, there's a pretty famous guy, his name's Tate Shanafelt. He does a lot of work around burnout resiliency and specifically in medicine. And he had this study that said, if 20% of your work week is dedicated to things that feed your mission, at least 20%. Obviously, if you could get 100%, great. But if 20% of your work feeds your mission, that is the key to successfully staving off burnout. And then I think realizing that if your cup is completely empty, you're not going to be able to continue to take care of other people. And getting away from this like savior complex or like I'm fixing people. I'm not fixing anyone. I'm not saving anyone. Nobody needs saving. What they need is somebody that can help them navigate a complex situation with compassion and dignity, like preserving their dignity and advocating for them when they don't know how to do it because the system is jacked up and confusing. Like it's not because these people are not highly capable humans. It's that we've created this system that is not okay. And so how do I help people navigate, guide them, give them knowledge, educate and empower, but I'm not fixing anyone. And so once you detach yourself from this idea that you are fixing anyone, then it's quite rewarding because really I feel like if I show up and I'm kind and helpful and figure out one extra piece for them that can help them live a higher quality of life, then I have succeeded. And so celebrating smaller wins and then figuring out what it is that you love outside of medicine or outside of your job, whether you decide medicine or not. So what is it that feeds your cup, fills your cup, feeds your soul? Whether that's relationships with other people, or you like to do some sport or some athletic thing or prayer, religious community, whatever it is that is meaningful for you, making sure you make time for that so that you are still whole is really, really important.
That's a great question. I think we sometimes confuse what is our mission, like mission driven versus what we're good at.
Mm-hmm.
And being able to realize we can be good at things that make us tired.
Mm-hmm.
And we can be bad at things that actually fill our cup. And so disentangling those two. And I think internships are a great way to learn. Actually, I feel really energized when I get to spend a lot of time in those relationships versus I'm kind of tired. Like I'm really good at this behind the scenes computer work and I'm great at it and people love me doing it. And it does not fill my cup. So I have to balance that with other things. So hopefully this summer will also give you some time to learn that about yourself. It's a lifelong journey, right? What parts, you're still probably going to have to do things that you're good at and don't love doing, but learning how to balance some of those things.
And I will say, some of those things that you maybe are good at, but don't like doing, you can outsource. So like, is there somebody else in your community that really likes to do it and is willing to do it for you? Or do you have a partnership and there's somebody, I hate doing, I hate doing dishes, but I don't mind cleaning the bathrooms. So and I don't hate doing dishes. I hate when dishes have stacked there for 24 hours. If they are not done right away, I'm not doing them. I'm not doing them tomorrow. My husband does not mind like going through dirty dishes and putting them in the dishwasher. I refuse to do it, but he hates going to clean the toilets. I'm like, I don't know. I go in and shut the door, put on my music. I do my own thing in the bathroom. So like, what are the things that like includes not just professionally, but what are the things personally? Like, I don't really love going to the grocery store, but I love cooking. So if my husband is willing to go to the grocery store, then I will do the cooking, in the household. And so figuring out those partnerships in your community that you can decide you do and you don't do.
I love that. Any other questions?
Sorry, I just knocked my plug. Give me 1 second.
Anybody having questions? I know it's almost 8 o'clock on a Tuesday, your second week of an internship.
I have a question about the mobile health service that you were just talking about.
Yeah.
I know that you mentioned like the language barrier, and then I was also just thinking about like the stigma around seeking help in any form. So I was wondering if there are any like practices or techniques that you and your team have come up with and then implemented that like are intended to reach more people or even just make the woman already coming to you like more comfortable in seeking help.
Yeah. So I think it's really important to explain one of our best things about being a doctor is I actually don't need to know anything about their documentation status other than so I'll often ask about their insurance situation so that I can figure out how to best make their care as cheap as possible for them. So sometimes people are eligible for like emergency Medicaid, which doesn't pay for prenatal care, but it will pay for the delivery. And so like kind of helping to know that. But I try not to ask too many questions unless they come to me and they're asking for support in figuring that out. One of the things that's very interesting here in Tucson is I'm often caring for people who are in Border Patrol custody. And that's a whole nother thing. And there's a lot of rights around that. And so actually give the talk for the entire campus of University of Arizona about knowing your rights with Border Patrol and Customs and ICE and other services that are involved, and recognizing that there are things that I can ask of the Border Patrol agents because people that are in Border Patrol custody are not actually incarcerated individuals. And so there are things that you can do that are different. I also take care of people who are incarcerated, which is a whole nother thing, our justice system here. But the incarceration stuff is also very interesting, where like, I don't want to know why somebody's incarcerated because that's not my job, right? Like my job as a doctor is to take care of their medical needs. And it doesn't matter if they're a pedophile or if they killed 4 people, or like, that is not my job, is not to judge or to decide whether they should be incarcerated or not. My job is to treat them with as much dignity as I treat the person next to them. And so I think really making them feel safe where we run the mobile health unit, we actually now are doing it out of a school, which I think is a really comfortable place for people to be. There's like a classroom that's set up for kids to do and things that they want to do, and like bright colors and toys and free books and free supplies. We often have donations with car seats and other things. And so I think they really do see us as a service, but we don't ask a lot of details because we don't need to know. Yeah. And if you guys speak other languages, it's super helpful. So keep up your skills. I would recommend, I think sometimes in college, if you want to have a second language, like I spoke Spanish starting in 8th grade, but then when I got to college, by continuing taking Spanish classes, I was getting into like Spanish literature, which was not something I really wanted to do. I wanted to be able to speak Spanish. And so I kind of put it to the side for a while, but then when I went to residency, really picked it back up and committed to relearning medical Spanish. And now I do my encounters. I'm bilingual. I would not say I'm fluent, but I have bilingual certification to do all my encounters in Spanish. So whatever language or second language you all may speak, it does come in handy. Like a lot of our residents speak French, and we have a lot of refugees from Africa that speak French. We have some Arabic speaking patients and Arabic speaking residents. When I was in San Francisco, all sorts of Asian languages that were spoken. It was amazing to have residents that spoke Cantonese, Toisanese, Mandarin, Vietnamese, all different languages like that. So don't let go of your language skills if you have them. And if you have them, try to join like a group where you can just use them conversationally, because it will come in handy with your future jobs.
I think we have at least one intern working and doing translating at Crossover. So helping actually with patient care and kind of translations. We have at least a couple who are working on medical Spanish. We have some Arabic. We have, I got to look through y'all's registration at all the different languages. So it's amazing. And
we need you.
I know many of y'all are not going into medical fields. So do you have any final advice for these interns for their next 6 weeks, whether they're in medical settings or law settings or working in shelters, that sort of thing, how to make the most out of the next 6 weeks?
So I think that just stay curious. So any opportunity that you have to lean into something, do it. You may be surprised where like something leads you, and you may find out like, oh, I thought I wanted to do X, Y, or Z, and now I'm really into research, and or I'm really into like writing grants or grant writing policies, all those things. But definitely don't be afraid or shy to try new things. So when an opportunity presents itself, take it. And then really pay attention to people's stories. Ask questions of your clients, ask questions of your patients, ask questions of the people that are doing work that's interesting to you. How did they get there? What were the things that were most helpful for them? Networking is huge. Like, do not be afraid to reach back out to these people that you've worked with this summer. I kept in touch with Dr. Maslansky, who I told you about. Like, I ended up, we became like pen pals. So I was like pen pals with this 80-year-old man. And we would write letters back and forth to one another. And he really was super influential in my life. And so don't think that your internship or your connection ends here. It can continue. Next year, you can reach back out and say, I was wondering about this, or you never know kind of where it may lead you. Yeah.
So those LinkedIn connections that we all hate doing, we should still do them.
Yeah.
That's my plug.
And
everybody's like,
a handwritten,
do it anyway.
I'm an old soul. Handwritten thank you note after your 6-week experience. Please tell the people what they've meant to you. They are passionate about what they're doing, and you will be like the standout that wrote an actual handwritten letter to them. They will never forget it. And then I think Jen's advice is great. What do you love? What does spark your interest and your joy? What pieces of your job? Maybe you decide, I don't want to do housing policy, but in the housing policy realm, the piece that I loved most this summer was talking to the client, or was working with the children of the clients, or whatever. Kind of take those mental notes and decide, like, what are the things that spark your joy? Because there are so many jobs out there that you can craft to meet your needs and to serve the world in abundance. So, and I'm happy to be a resource. I will put my email in the chat, and Jen, you can send it
That's
out
perfect.
too.
We have a couple other questions that, like, I may see if you can, like, help to get some links where some people interested in about kind of the asylum process and the training. So I may have you kind of help me. I tried to track down links as you were talking for some of it. And I will kind of put this in Canvas too. I'm not as good at GroupMe as everybody else, but I will try. But it will be in Canvas with the recording. Abby, did you have a question? I saw a hand raised. If you did, I wanted to get to you. It also could be. There she is.
I just wanted to. Can you hear me?
Mm-hmm.
Yeah.
Okay.
Yeah.
I just wanted to say that it's a huge inspiration to me to meet another English major who's also doing exactly the kind of medicine that I want to do in the future, working with like uninsured patients who have like complex immigration status. So I'm so excited that you're sharing your email, and I would love to maybe connect with you, Doctor, if
I would
you're
love
okay
that.
with that.
Yes, please.
Yeah.
Please.
Awesome.
And Abby,
Awesome.
you're doing translations. You're working as like a translator with crossover. You were my example, right? Yes. Okay.
Yeah. Yeah,
I was
exactly.
quizzing myself on where everyone was, and I'm getting
Abby,
them.
send me an email. We will connect for sure. And
Oh my
anyone else,
gosh.
yes, I would love to connect with you.
Awesome. Thank you.
So it is 8 o'clock. I want to be respectful. Feel free to like send email. I will make sure everyone has Dr. Meehan's email. I'll put it out with a recording. This is one of the greatnesses. I was not an English major. Of the SHECP network. The people who did internships, we've been doing this for about 25 years. Those who have done it in the past loved it and love to be able to help the next kind of iteration of interns. So just as a reminder to talk shop, there are 4 of these this summer. There are this one, the next 2 Tuesdays. Yes, then we take a break, and then July 11th. We ask that you come to at least 2 and do a reflection. If you want to come to all 4, I will bring like Tootsie Rolls to the conference and give you, like, whoever makes it to the, more than 2, I'll owe you a Tootsie Roll. So that is all we have. Thank you so much for coming, and thank you for presenting on this Tuesday. Y'all are good?
Really
Oh,
quick,
we're good.
Thanks so much for your time. Have a great one.
the asylum trainings, it seems, I don't know how you can get involved in it earlier than medical school, but I'm sure there are ways. So I will do some research on that and then let you guys know.